So I will begin by asking the members of the commission first to introduce themselves, and we'll begin.
Good morning. My name is Ellen Gorman, and I'm a former associate member of the Maine Supreme Judicial Court.
Good morning. I'm Paula Silsby. I'm a former federal prosecutor.
Good morning. I'm Anthony Ng. I'm a psychiatrist up in Bangor, Maine.
Good morning. I'm Toby Dilworth, and I'm a former federal prosecutor, and I'm a practicing lawyer in Portland.
Good morning. I'm Jeffrey Rushlaw. I'm a former district attorney and retired district court judge.
And good morning. I'm Dr. Deborah Bader. I'm a retired forensic psychologist.
Good morning. I'm Ann Jordan. I'm the executive director of the commission, and I'm an attorney.
Good morning. I'm Brian McMaster, retired chief of investigations for the Attorney General and investigator for the commission.
The person who is appearing this morning is Colonel Ochoa, and I would ask him to introduce himself at this time.
Good morning, sir. My name is Mark Ochoa. I am the United States Army Reserve Command Surgeon. I've been in this position for almost a year, but about 10 months. I am OBGYN by background. Appreciate this opportunity to be able to appear here. As we all know, mass shootings and such are absolutely horrible, and being able to be a part of this to this committee, if we can come up with solutions, if I can do my small part for that, appreciate that. Maine has always been special to me. On my second deployment, went to Bangor, Maine, and I recall going to the airport, and people from the town came out, and with flags and treats and phone cards to call home. So that is always obviously still remember that. And then last summer, my wife and I went out to Maine and experienced the coastline, from Acadia on down. And the people are so friendly, the food is good, it's such a beautiful country, the botanical gardens and such. So just to kind of put that out there, sir, but open to questions.
Well, we appreciate your cooperation and your willingness to acquaint us with the operation of mental health services that are available to the Army Reserve. And we're glad that you had a good welcoming in Maine. I can't think of a better welcoming than you've described. So come back again and we'll try to outdo that. So
yes, sir.
Leading off with questions on behalf of the commission is Dr. Bader, and then others will have an opportunity once she has concluded her questions. Dr. Bader.
Thank you. Good morning, Colonel Ochoa. Good morning. So could you just describe your current responsibilities?
So yes, ma'am. So I am active. I'm an active duty officer. There are, within the surgeon section, there's two, the doctor and we have a dentist. I'm the principal advisor to the commanding general on all things readiness, training, equipping, maintaining, mobilizing. We have several different sections. Many of them are congressionally mandated that we need to do within the clinical arena. PHP psychological health program is one of those that we're here to discuss today. But as far as we do deployment, we do management of providers, we do profiling. So pretty big spectrum as far as what the team here does.
Thank you. And can you describe the Army Reserve Psychological Health Program, for what the services are, how to access those services, etc.?
Yes, ma'am. So the Psychological Health Program is congressionally mandated. So there's a Department of defense instruction, 6490.09, that kind of describes, lays out what we need to do. In brief, or essentially, they are a resourcing program. They do needs assessments, they do command consultation, they do education, and then for traumatic events, so for instance, with the Jordanian attack last fall, that they do crisis management afterwards once soldiers return home from deployment to talk about needs, concerns, etc. I will say it's very different than Compo 1 as far as that they don't provide care, that they're a resourcing, and I can't stress that enough. We try to lead them to where they need to go versus there's just a big difference, ma'am, with Compo 1 and Compo 3.
Can you, I'm confused about, I'm not sure I'm hearing Compo 1 and 3.
I'm sorry, Compo 1 is active duty. So someone like me that wears a uniform every day, I have a responsibility to report. We do what's called PERSTATs, as far as a commander having authority over me, if you will. Compo 3 is reserve. Compo 2 is our guard. Compo 3 are reserves, and so they're under the authority of a commander to on the weekends during their drill time, if they choose to go to drill, because it is voluntary, and then 2 weeks of the summer. So healthcare is very different in the reserves, Compo 3, because they may or may not have healthcare, and that's why it's important to have programs like PHP that helps link them to care. And as I mentioned, that resourcing piece, because if you're not on orders, you don't have access to TRICARE. They can get TRICARE Select, where they can get care, but unfortunately, many of our reserves brothers and sisters don't have medical insurance, and so that's really what PHP does, is help link those up with those resources so that we can take care of folks. We have commanders, if you will, that may not be familiar with healthcare, and so that's one of the big reasons that we have them, to help that bridge, because commanders, like the soldiers, this is their second job, extra duty, and so I really feel it on us as a surgeon team that we need to do everything we can to help support those commanders, because they're working two jobs. That this team is that and that's what they do, man.
And how well promulgated is the PHP throughout the reserve system? For example, would most commanders be familiar with this as a resource?
Well, I would like to hope so, ma'am. About every month, minus I think 3 out of the year, either myself or my deputy, we brief at the pre-command course, battalion and brigade pre-command course, and we have a handful of slides that we introduce or talk about that program. So that's what one way is, just formally getting in front of the commander and say, we have a program to help you, and then we have their points of contact to include myself or my chief, etc. Other ways, so at group events, so whether it's at a training event or a yellow ribbon event where we have touch points with soldiers and their families, we set up as far as areas with information to reach out and touch those soldiers and their families, and then as asked, so commanders will also reach out and have those that know about it, for training and such. So would I say all? I'm sure there's some that don't, but we try to get that information out, especially with May. That was Mental Health Awareness Month, so we really pushed it. So at all command venues, when I have time with the CG, on weekly or biweekly touch points. We're putting that out as far as our PHP program, and so to take opportunities to be able to self-advertise, if you will.
And can reservists access the PHP, or does it
Yes, ma'am.
have to go through a commander?
No. They can access it directly. Yeah.
How would they typically do that?
So either the phone numbers out there, or our folks are reaching out to them. Quite honestly, we have different feelers, if you will, and so if there's ever an issue, what I really like about this team is they're proactive, because in this matter, you can't really wait for it to come to you. So I would say that our team is very proactive. So if there's something called CCIR, so those are critical information requirements that commanders put out. So events that happen, if there's a soldier that has some behavioral health concerns, the team is reaching out to contact them. If we have what's called a PHA, a periodic health assessment, which is a yearly touch point that we all do. And so if there's any concerns with a behavioral health, then the team is notified and brought in on that.
Are you made aware of command-directed behavioral health evaluations?
I'm not aware of everyone that happens. However, this team helps complete those. So I would say there's two different kinds. There's urgent and then non-urgent, if you will. So urgent, someone's wanting to hurt themselves. This team is fantastic in that if there's someone in crisis but stable, if you will, the team will reach out to the military MTF, which is ideal. So military treatment facility, military hospital, reach out, make that point of contact, so that, you're not just dropping someone in their lap without them knowing. So pre-coordination, getting whatever records may be available, they help that movement. So they advise that commander on how that works. If there's no military treatment facility close, then obviously a civilian location is what happens. Now for the less urgent, if you will, someone that we don't have to take them right away, there's more coordination with the team. For instance, if it's for remote and we got to travel and such to help get that service member to care.
So just so I make sure I completely understand, so how are you made aware of a command-directed behavioral health evaluation, for example?
I am made aware when someone asks for assistance, and I link them up with PHP program.
So you're made aware by a request that comes from,
Yes,
for example, a commander.
Yes, ma'am. So if a commander knows how to do it, has done before, they don't have to go through my shop. I'm not a roadblock for them. I'm hopefully an enabling agent.
Okay. And so from what you're telling me, it's my understanding that, do you offer specific programs, or is it really entirely linkages to programs that exist in the community?
I would say it's variable. It depends on the resources available within the area. More remote places, then yes, it'll be linking with resources that are needed. So, then that's part of their needs assessment. Now, I've been an Army doc, so I think more triage, but they call it a needs assessment. So, triaging as far as, hey, is this a financial concern? Is this a relationship concern? So if it's a relationship concern and, not necessarily requiring a behavioral health provider, but needing someone to talk to, well, that resource may be available with either like a chaplain or a MFLC, which is a marriage family life counselor. So they may have those resources available. Now, if it's, if they're remote and need health care, i.e. to see, you know, a clinical provider, then the team will look out, you know, hey, what kind of insurance do you have? What providers are in the area, and coordinate that linkage, ma'am.
So the linkages are either within the resources available to the Army and Army Reserve, or linkages into the community. Is that
Yes, ma'am.
correct?
Yeah.
Okay.
Yes,
right.
ma'am.
All right. And what type of follow-up, if any, happens after someone is referred to your program?
Yes, ma'am. So follow-up, it depends on acuity, if you will, or risk. So if someone's higher acuity, that the team is reaching out for ease, probably weekly, because they'll do either 3 times for 5 weeks or 5 times for 3 weeks based on their acuity. But for ease of numbers, and for me, weekly, they'll reach out. They'll reach out either via email, via text, phone call, and then they document that attempt, if you will. Well, if they contact them, you know, they'll document what they did. If they can't, they generally link the company commander, so that there's awareness. Because we, as a medical community, you know, we aren't, we make recommendations to commanders who make decisions, but we keep them informed. We're there to assist commanders to make the best decisions that they can. So, but so part of that, so part of it's reaching out and documenting, hey, did you get your follow-up appointment, etc. And then I have another team called ARMIC, Army Reserve Medical Management Center. They're down in Florida, but what they do is a profile piece. And to me, a profile is very important, because that is the formal communication from a provider to a commander. So, you know, for instance, for behavioral health, if there is an issue, they will put someone on profile. No weapons, no live fire activities, no range, etc. So we keep that profile, one, to protect the soldier. For instance, profile other usage would be like, you know, if Mark Shaw has a knee pain, you know, no running for 4 weeks. So that's to protect me. But it also protects the command in that, you know, giving them recommendations to not only protect the service member, but to protect the group or the force. And then we follow that. The challenge, as I alluded to with active, commanders have commanders are more trying to think of the best term, as far as in contact with the service member or in charge of the service member. Because in Compo 3, if you don't go to your appointment, or you know, because it's all volunteer, so our team only knows what they know. So if they don't get medical records from that civilian healthcare provider, that soldier's not releasing it, it's hard for us to shape or modify without getting information. You know, it's hard to do things in a box without that input. We continue those profiles, and there's that continued engagement. So we have PHP reaching out to the service member. We have ARMIC also reaching out, so that we're all in sync, and they all chart in the system where they can see. So it's cross level.
So, Colonel Ochoa, if someone is referred to you who is considered dangerous to themselves or others, and is it fair to say that, so the referral has been made, let's just say, for example, the referral has been made, the information that you have is the person is in some kind of acute mental health crisis. How is it fair to say that the commanders are kept fully in the loop with respect to whether they have accessed treatment, whether they're, for example, answering your follow-up phone calls, responsive to you reaching out to them, during and after treatment. Is that a fair characterization?
In the military, we have HIPAA for commanders. So medical information that commanders need to know to keep soldiers safe, to keep their unit safe, to take care of folks. So there is that communication. The challenge is with Compo 3 reserve is when that medical asset is outside of the military health system, that they don't have that access. And so if you're command directed and you won't necessarily get that information because you don't have those contact or that ability, because that's not done in civilian healthcare, as you're probably aware, ma'am.
Yes, but that notwithstanding, is it fair to say that someone's been referred to you, let's use that example again, someone's been referred to you having been or in a acute mental health crisis, your team is going to follow up
Yes,
with
ma'am.
them. Yeah, I know
Yes,
it's
ma'am.
voluntary on the part of the reservists whether to release
Yeah,
information. I understand
we are,
that, but
yep.
your team is going to reach out to them, and you can then report whether that follow-up, that reaching out, was successfully accomplished. You can report that to their commanders,
Absolutely. Yes.
and that's routinely done.
Yes, ma'am.
So, for example, if someone's referred to you who has been in an acute mental health crisis, and you reach out to them, and they don't respond, let's just say, you
Yes, ma'am.
can report to their commander that they're non-responsive.
Oh, yeah.
Okay.
Yes, absolutely. 'Cause that's part of accountability when you're concerned about someone's overall well-being. So in the active side, if Ochoa doesn't come to work, the commander wonder where I'm at. So it's the same thing for reaching out. We want to make sure the command's aware, so that so that we're all on the same sheet.
Okay. I think I know the answer to this, but is there any ability to mandate, other than a command-directed, behavioral health evaluation, is there any ability to mandate that a reservist get treatment?
Other than command directed, yeah, there's not that authority as there is in Compo 1.
Yeah, I figured that. I thought I knew the answer to that, but
Yeah, in the active side, we have what's called embedded healthcare. So we have behavioral health providers at all levels, social workers, psychiatrists, psychologists, that are embedded with units for that, so that people can go in, out, get their health care what's close to their place of duty, if you will. We don't have that in the reserves, ma'am.
yeah. Okay, thank you. And just in terms of statistics, Colonel Ochoa, what's the usage of your program?
So it's
just excuse me, just 1 second, Colonel Ochoa. We're going to switch interpreters here.
Yes, ma'am.
So
yes, ma'am.
So just hold on. Are we? We are. There we go. You all set? All right. So back to my question, Colonel Ochoa. What's the overall usage of the psychological health program?
So I'm going to step back and kind of just describe as far as how it's laid out. So here within the surgeon section at Fort Liberty, I have two teammates that kind of oversee all the program. The reserves are broke up into 4 RDs, so kind of across the United States, cut in quarters, if you will, based on population troop strength. Within those 4 quarters, I have 4 providers that are PHP that's kind of serve those areas, so that they get to know what's available, what resources they have in those areas, etc. So on average, they're getting anywhere from 50 plus or minus probably 20 new or I'm sure that not necessarily admissions, but kind of asks, if you will, to manage cases. And as I talked about before, they might be relationship, they might be financial, they might be unemployment. And so out of those 50 per month, so, 200 over all the reserve, well, maybe there's 20 out of those that are 20 per month per RD-ish, give or take, that they are tracking and trending.
And the only way that you have, any of your regional folks and yourself, the only way that you have to sort of track the mental health of a particular reservist is if they're referred, either self-referred or referred by their commander for some assistance in linkages.
Well, as I mentioned earlier, we pick up through
Right.
other, so PHA, so there's other ways that we can get those cases or self-referred. So it doesn't necessarily have to be that command. That's probably the most severe. So if a family member calls in, then they're reaching out to. So there's all different. And that's what I like about this team. They're proactive, they're receptive. If they feel like there's an issue, so they email concern, hey, so and so might be having a problem, then we go to the correct PHP team to help reach out.
And do you actively outreach to family members of reservists?
Yes, ma'am. Those are in yellow ribbon programs. So those are events where the reserve on the weekend will have many times can be associated with a pre-deployment or post-deployment, and that's where they set up a table to discuss their services, discuss resources that are available, contact, and so yes, the team does get input from family members.
And like by family, can that include, obviously include spouses, but can
Yes,
it
ma'am.
include siblings or parents?
For a psychological health perspective, if there's a concern and it's brought to a team, they're going to take it, ma'am.
Okay. And are there any have any outcome studies been accomplished just through in the Army with respect to the efficacy of your program?
Not that I'm aware of, and so the program is managed by contract, and so outcomes in behavioral health are hard. Even on the active duty side. So, we track suicide statistics and net numbers, and there's been a bunch of different ways that we're trying to figure out how to reduce it. But as you're aware, suicides across the United States have increased since early 2000. So, and the amount of resources that we all have, whether civilian or military, are not to the level that we need them. So recognize all those, but I'm not aware of outcome study. But as far as as I sit in the seat and we look at new contracts or updating it, measures of performance, measures of effectiveness, get our smart team together that know behavioral health. What would be good metrics that we can measure that by? Because as you know, that's hard.
It is. All right. So is it your understanding that there are some perceptions within the reserve community, even commanders, about concerns about if they refer to your program, i.e., does that affect things like security clearance? Are there concerns about a profile being developed, which you discussed earlier? Is that a concern that might inhibit commanders or reservists from reaching out?
Of course, the answer is yes, because it's in the media how it's, people are concerned about a behavioral health condition, but what you know, it is a medical condition, should be treated as such. You know, high blood pressure, headache, and so if there's a diagnosis that need treated, we need to make sure that we treat that. What I have found is commanders are there to support their soldiers. So no, that they don't have to be told, but they really have the ability to reach out and get them help, and that's the message that I want to get out to the team. Commanders have those reasons. You know, commanders should know about PHP so that they have chaplains on their team. They have the MIFLICs. Commanders have the tools to help their teammates. So I have heard that people are concerned about progression in their military career, etc. But there have been a lot of successful people that have had you know, overcome those challenges, if you will.
Okay. Well, thank you. I'm going to turn the questioning over to my colleagues. I see Dr. Ng has his hand raised. That might help you, Kevin. But thank you, Colonel Ochoa.
Yes, ma'am.
Hi, good morning. Oh, good morning,
Good
Colonel.
morning,
Thank
sir.
you. Yeah, thank you for making the time to participate. And Dr. Beta covered many of the questions. So I just want to get some clarification. So you mentioned about compo 1, 2, and 3. So 1 is easiest in the sense like, you know, your active duty, you can always do a lot of things there. With compo 3, is they have jurisdiction while they're on duty, correct? When they're under
Yes, sir.
the weekend drills or whatever it may be.
Yes,
So if a commander has instruction to say it's a commander responsibility follow up to make sure the person get care, is that a reasonable expectation when they have no control over that person between between duties?
I would say that's where our PHP team helps assist. So
Okay.
they're filling in those gaps. So if someone's has an appointment, has care, you know, that's what my team is there to do, is to help
Okay.
those commanders track
Okay.
that people are getting the appropriate care.
Okay, so it's not like they need to make the person go. They just need to make sure there's a linkage that can continue to keep an eye on the person, even when they quote unquote not on duty, correct? So for example, like I'm saying, like a commander say, okay, I need your help from a team because I have a service member who needs, you know, care because they were either requesting it or they have recently been in a hospital. You guys take over from there in terms of reaching out to the service member, correct?
Yes, sir.
And the service member said, no, I'm not interested, or doesn't respond to you, you folks will relay that back to the commander and say, hey, your referral for
Yes, sir.
so-and-so did not follow through. At that point, that commander may or may not have any oversight because they can't make the person go, correct? Because the person is now in drill. The person...
It is different than active duty. Yes, sir, as far as having that authority. First, when you're active and it's not a voluntary. So yes, it is different, sir.
Okay, so there's no automatic triggers that reminds the commander to call you guys as soon as someone encounters the mental health services. So if someone go to hospital, the commander says, oh, the process automatically triggers a notification to PHP. It's still up to commander to remember if the PHP exists to call you. Is that correct?
Well, I'd say not necessarily. So if a soldier is hospitalized for whatever condition, motorcycle accident,
Okay.
the commanders do a CCIR, Commander's Critical Information Requirement. So
Okay.
that's done it's pushed up the chain. So commander doesn't have to reach out to me. My team, to include myself, we see those, and so can act on those. So there's several mechanisms in place to make sure that we're there to support commanders at echelon.
So, and I apologize if I just need a little clarif. So if a person was hospitalized, you would be your office would be notified that someone got hospitalized psychiatrically.
Well,
Without the commander calling the phone.
It depends. So if someone goes to a civilian facility, command, Army, Reserve is not involved. We don't know. We only know once it's identified, and sometimes it's after the fact. Now, if
Okay.
it's a command directed, obviously we know we're engaged with those. But if someone's getting outside in civilian healthcare, we don't know unless the command notifies us or it's brought to our attention through some other means.
In this, we're talking about command directive where a person went to a civilian hospital.
Yep.
Would that have triggered PHP?
Yes, yes, sir.
Okay. So
within the command directed arena, our PHP helps with that. But I'm not going to say that's 100% of the time. But because if a commander has done the system, well, if they know the system, they generally involve us. But if they are concerned about a service member and they're taken to a hospital, we will end up I would say generally we end up getting notified at some point.
Okay.
But sometimes we do it at group events. So I mentioned the PHAs where the periodic health assessment. It can be elevated at that time, and then the contracting agency a different one that manages PHAs, they notify us as well. So there's multiple ways that we have out there to stay into.
So if a commander do a command directive for a service member who went to a military clinic first before any disposition to what they end up doing, even the commander forgets, the clinic would have notified PHP because they were the one who made the. Is that that's not 100%?
No, sir.
Okay.
And the reason is if a service member, if you're a reservist and you go to a military treatment facility, we in active use one EMR, electronic medical record. It's called MHS Genesis.
Okay.
The Compo 2, the Guard, and the Reserve use a different EMR, if you will. So they don't communicate. MHS Genesis Compo 1 is no online, so there isn't that direct communication, and even seeing charts can be challenging.
So when they Compo 2 and they're on duty, are they Compo 1 or are they still considered Compo 2?
So they're Compo 2 or Compo 3?
3, sorry, yeah. If they Compo 3 and then on deployment.
Reserve, they're on orders where they get Title 10 active duty privileges, if you will.
So if they deploy on the weekend or the two weeks in the summer, they would be under Compo 1 at that time.
Well, they're still Compo 3, but they're under orders where they can get Title 10 care.
Yes. All right. Thanks. Appreciate it. That's it for me. Thank you so much.
Okay.
Colonel, my name is Paula Silsby, and I have some follow-up questions for you. If a serviceman's or woman's family is looking for help with respect to that reservist.
Okay.
Can you hear me?
Yeah. Yes, ma'am. I'm sorry.
And that need was conveyed to the reservist command structure. What is the protocol that should ensue?
Protocol with reference to what?
If a reservist family members are looking for help with respect to that service person because they're concerned about his behavior, and that concern is brought to the attention of the reservist command structure, what should follow from that?
So if a commander is notified by a family member about a concern of one of their service members, it would depend on the issue. So the commander has different resources available within their toolbox, as I mentioned. So whether it's chaplain or MIFLIX or Army Emergency Relief, AER, financial concerns. So, they disposition out through there. If there's psychological health, behavioral health concerns, obviously they generally reach out to us, or if they have a surgeon. So, Compo 3 structure is a little bit different as far as some have more medical assets than others. So those with medical assets can lean on those assets, i.e. if they have a doctor or nurse or a medic on their team, then they utilize the resources within. So it really depends on the unit and what resources are available. And there's a fair amount of variance within the Reserve Command, ma'am.
But if it is a behavioral health concern, the appropriate protocol would be to connect the family with the PHP program. Is that correct?
That or directly with behavioral health. So with some medical resource, I would say. As I mentioned, if they have a surgeon, that can sit and talk with them and put in a referral or link them up, we are just one tool in that toolbox to help take care of that service member.
Okay. And in the event that you have a reservist who is not responsive to your outreach, to PHP outreach or ARMCC outreach, and that is made known to that reservist commander, can that non-responsive conduct be the basis for another command-directed evaluation?
It could be one piece of that puzzle. Yes, ma'am. And that's why we document. So in medicine, if we don't write it down, it didn't happen. And that includes the negative event. So if you're not making contact or, elevating that up, but, for commander to make that decision, that's just one piece. Because unfortunately, in reserves, if they change their phone number, if they change their email, which seems to happen more frequently than I would think, so that contact, so that's reaching out to the commander. Hey, we're trying to reach out to them. We don't know if they are well or whether they just changed their connection pieces that we can't contact. So I'd say it's a piece of that puzzle, ma'am.
If we could hold on one second, Colonel, we need to change interpreters.
Yes, ma'am.
We all set? Joe, we okay to go?
Yes.
So that is a tool that's available to a commander who's made aware that his service person is not cooperating with PHP or responding to PHP.
Well, either not cooperating or change their contact information. It's one piece, ma'am.
Yeah. Now, is it, if PHP and ARMCC are reaching out to a reservist and there is no response, and there has been notification to the commander of this fact, is it appropriate that the case be closed because of no contact?
From a medical perspective, I don't think.
Is it appropriate for PHP to close the case because the service person is not responsive to their attempts to contact them?
No, ma'am, as long as they're within the reserve community. Because we don't know about the wellness of them. So even with our profiling, that's kind of, our way that we track and trend, that they continue the profile, even though we might not get medical updates and such. So
I think I'm maybe confused by your answer.
Okay.
If there is PHP follow-up after a reservist is discharged from a 2-week hospitalization.
Yeah.
And that reservist, and the contact information is correct, the right telephone number, the right email. The commander knows how to get in touch with the reservist, but the reservist is not responsive to PHP's attempts to reach out, doesn't respond to emails, doesn't return phone calls. Is it appropriate for PHP, after several attempts, unsuccessful attempts have been made, to close the case?
No, ma'am.
What should be done?
Well, it's hard, right? Because our folks are remote, so we continue to make that contact, and we continue to document said contact.
Well, let's assume that this goes on ad infinitum. What are the expectations from a non-responsive reservist in this situation?
From a medical perspective, we are always here. So I would say that would be a command decision as far as how they move forward, because it's not just, are they going to their battle assembly or so from a medical perspective, we're not going away, ma'am.
If somebody calls the 1-800 number that's available for help for people of family members and people in various branches of the service, would you expect that a referral to PHP would be made through that phone call?
I would I would hope so. I mean, that's what we're here for.
Now, can you explain to me again the periodic health evaluations? Is that something that every reservist undergoes on an annual basis?
Yes, ma'am. It's called a PHA, Periodic Health Assessment. And essentially, it's an assessment. It's not necessarily a medical appointment. A physical exam isn't required, although some based on age, whether labs or colonoscopy, etc. But it's a touch point with a provider. A service member does an online portion, and then a provider reviews that, and then as needed, consults are made or follow-up are completed. The requirement is annual. It can be extended out to 15 months. But yes, at all echelon or all compos 1, 2, and 3, we all do those, ma'am.
So if I'm understanding your testimony here today, Colonel, that PHP is a resource. It's there for people who wish to avail themselves of that resource, but ultimately it comes to the reservist commander to manage the situation if you have an uncooperative reservist. Am I correct in that assessment?
We are there to help commanders the best that we can, either with recommendations, get guidance, instruction, training. So I don't like to think that the commanders are out there on their own. They have a tough job. We're there to help them. We're there to help them with their tough job any way that we can.
Right, but it's their commander's responsibility to manage an issue involving those under his or her command.
Commanders are the authority, that they have the authority, if you will. Me, Mark Cho, I don't have that command authority. So yes, I make recommendations. My team makes recommendations, but commanders make decisions, and that's why they have staff. Like my commanding general has my staff to help inform her.
All right, thank you, Colonel.
Yes, ma'am.
Good morning, Colonel. My name is Ellen Gorman. You explained to us that the PHP system is broken into 4 quarters. And I imagine there's a northeast quarter that would be responsible for Maine. Is that accurate?
Yes, ma'am.
And within the people assigned to the northeast quarter, how do any of them become familiar with what services are available to Compo 3 members in the state of Maine?
So, within their areas, there's some amazing resources as obviously preparing for this, seeing what's out there. For instance, there's a website called Get Help. That Get Help is really amazing. So they have, if you're food insecure, where can you get food from certain churches? If you need, clinical care, where can you get care, employment? So they utilize multiple different areas to be able to see what resources are within that area, and then there's a lot of variables. Do they have insurance or not? What providers are in the area? So there's that they are assigned to those areas, so they get to know those. But yes, you're absolutely right. When you got multi-state, multi-county, it can be hard. Yes, ma'am.
And so if the actual personnel of the PHP are in DC or Boston, unless they have some historic connection with a mental health provider in Maine, they're like everyone else in Maine searching for an opening. Is that accurate?
I would say they have a list of resources available within those areas, that they go to in order to find that, ma'am.
Are there any?
I don't want to speculate on.
Okay. Do you know whether each quarter has a list of providers who have worked with reservists?
I'm not aware of a provider list. No, ma'am.
Okay. And if a commander were faced with a reservist who was undergoing crisis, is PHP available to the commander to assist him or her in how to develop a plan for the reservist?
Yes, ma'am. Absolutely. Yeah, they have, yes, that they have a SOP, if you will, as far as what needs to be done in order to take care of that service member. And that's what they're there. They're help to guide the commander to
And
take
so the
care of
commander
that.
could actually reach out to the PHP system and say, I have someone who's clearly troubled and I just don't know how to handle him. Do you have recommendations?
Yes, ma'am. Absolutely.
So it's not available just to the reservist. It's also available to the command structure.
Yeah. Oh, yeah. Yes, ma'am. Yes.
Okay.
And in fact, yeah.
Go ahead.
No, no. Yes, it is available to all commanders.
And over the course of our investigation, we have been hearing about access to veteran system, but the reservists, unless they have served in the active military, are not considered to be veterans. Is that true?
Or if they had a line of duty, line of duty is some medical condition while they're on orders in order to get care.
But generally, they would not be available for veterans services.
Again, if they have a line of duty or were previous active duty, and were eligible for a medical condition.
Okay. And for the people who are doing the outreach, are they themselves mental health providers? You've frozen up, I think.
His,
Kevin, I think I've frozen him.
well, there's a pin. Oh, no, it's same with you. Yeah, I don't know. He is definitely frozen.
This is Lieutenant Colonel Jennifer McKeel with the Army. Yes, he's frozen. I've reached out to him, so if we can just give a minute.
Thank you.
Okay.
Log back on, I apologize.
Hello, there's Mark Shaw. Can you hear me now?
Yes, we
I-
can't see
I
you
apo-
yet, but we can hear you.
I apologize. We've had some Wi-Fi challenges within office, and it appears I dropped.
There you are.
Am I on there?
Over
Okay,
someone else's,
so-
you have someone else's name on your screen though.
Yep, it's yes, ma'am. Well,
Okay.
one of our teammates.
Excuse me, they're mowing my lawn here, so I don't know if you can hear me or not.
Yes, ma'am. I can hear you.
So the people who were doing the outreach from PHP, would they themselves be mental health providers?
Oh, the staff from PHP.
Yes.
So there are licensed clinical social workers. They can be licensed mental health care providers. No psychologists, no psychiatrists. They are credentialed, i.e. based on the contract as far as what their background and certifications are, but they are not privileged. So as far as to provide care, so they do not provide any care, if you will, what you'd think of when you went to a clinic.
But in terms of being able to speak with the reservist and maybe, to use your word, triage how to best provide a link,
Yes,
they
ma'am.
would have those skills.
Absolutely. Yeah. And that's expected of them, and have confidence that they can do that.
Okay. And I understand that those people are contracted. Is there a single contract across the nation, or are they different contracts in each quarter, if you know?
What one contract? I'm not. Yeah.
Okay. Thank you very much.
Yeah. Yes, ma'am. And I'm going to jump to my other computer while we're standby. Okay, I apologize for that. Technical difficulties. Oh, did I freeze again?
Oh,
No. Are you able to hear me, ma'am? Okay.
Kevin, I think Ann's up. Oh,
I just
I'll
want
go if nobody else wants to go.
Okay.
I just have a short question. I want to
Yes, sir.
follow up. Good morning, Colonel. I'm Toby Dilworth.
Mr. Dilworth, I'm so sorry. This is one of the interpreters. If we could just pause and spotlight
Sure.
David. Sorry, we were a little bit behind. And I think we're all set. Thank you so much.
Thank you. I'm Toby Dilworth. Good morning, Colonel.
No, sir.
I just want to follow up on Ms. Silsby's questions. If a reservist is not responsive to PHP outreach, can his or her commanding officer order that reservist who's on a weekend duty on a battle assembly weekend to undergo behavioral health treatment?
If they're on a battle assembly weekend and they're on orders, then yes, sir.
Okay, and what does the commanding officer have to do to ensure that happens?
It depends on the resources available within that area. As I mentioned, if they have medical resources and they utilize those, if there's a MTF available, then they can use those. So it depends on the resources available, sir.
But that service member can be command directed to undergo treatment on a battle assembly weekend, just as on the 2 weeks
Yes,
service weekend.
Yeah. Yes.
Thank you. Nothing further.
And I have a couple of questions, I hope, only a couple. Good morning, Colonel. My name is Jeffrey Rushlow, and just for the benefit of the people listening to this program, if I understand it correctly, you are fully authorized to discuss your program, but even though our commission is investigating a particular reservist and particular events, you are not under any authority to discuss that individual and anything about it. Is that accurate?
That is true, sir.
So we're not dancing around the issue here. We're just, we understand their constraints on what you can say, and that's why we're asking the questions we are. So as far as New England, are there any military hospitals in New England that you know
of? I'm not aware. There could be a naval, but I'm not aware of any, sir.
Okay. And you're at Fort Liberty, formerly known as Fort Bragg in North Carolina?
Yes, sir.
And that's a very large facility. Does that have a military hospital?
Oh, yeah, yes, sir. Actually, out my window, Womack Army Medical Center.
And does that hospital have a behavioral health unit available for longer term care of service members?
Yes, sir. So the Department of Behavioral Health here at Womack is one of the largest in DOD, but we do have an inpatient floor. They have 11 inpatient beds based on staffing, of course.
Would there likely be any reservists in that facility?
Generally not. The inpatient beds here are predominantly with an active component. They will stabilize for a week or so. There's Camp Lejeune, which is out on the coast, and so that they have a much bigger unit. I want to say about 30 beds ish. If we get filled, that's where we tend to send folks.
Okay. But getting back to the command directed evaluation, if that's done at a military hospital or military clinic, is that clinic authorized to share the results of that evaluation with the soldier's commander?
So that they will share disposition, if you will. As far as the details, not necessarily. Is what do commanders need to know to keep themselves or keep the team safe? So information enough to protect the service member and to protect the unit is what's shared. But as far as like specific medications, type of psychotherapy, that's not shared.
But if, as a consequence of the evaluation, the evaluator recommends extended care, and in other words, a hospital bed, and the only hospital bed available is in a civilian hospital, is the civilian hospital authorized to share any information with the commander?
If the service member signs a disclosure and able to share, but I find that's very few and far between, sir.
So in a way, the service member, even if they're still under orders, it's not a weekend and the weekend's gone, they're still under orders. Their commander has a very limited ability to find out how their treatment is going. Is that accurate?
Yes, sir. Yeah, with civilian health agency, ideally, like most things, it's based on relationships. So nurse case managers are able to reach out, but if it's a civilian institution, they don't know a captain, company commander any different than a manager at Walgreens, if you will. So who wouldn't have a need to know. So that the civilian doesn't necessarily understand medical process or military medical processes and procedures.
So even
Nor
if
would
the
I expect
soldier,
them to.
even if
I'm
the
sorry.
soldier is still under orders, their status
Yeah,
is
there's that authority doesn't go into civilian institutions, or
even if they're still under orders, it's the soldier's willingness to share information with their commander which controls. And if they're not willing, then it's not shared.
check.
And but once they've been evaluated and referred to a civilian hospital, if they're still under orders, is the Army responsible for the cost of their care?
Yes, sir.
But once they're no longer under orders, who is responsible for the care, the cost of the care?
Then that would go to their civilian insurance, or if they have a TRICARE Reserve Select, which is pretty economical insurance, but for if you have limited resources, it could be more than what they're willing to pay for.
All right. Thank you very much. Those are all the questions I have.
Yes, sir.
Lieutenant Colonel, I have just a couple questions. You talked about the 1-800 number that reservists and or their families, I believe it was a 1-800 number, can call for referrals and for assistance. Do you know what kind of training the people on those, for lack of a better phrase, hotlines have as far as making referrals to families or assisting the families or a service member in getting help?
Well, there's multiple net numbers out there, ma'am, and some aren't under my purview as far as the military hotline, military crisis line. That's levels above me. As far as our psychological health, it's our team, if you will, and so a lot of those net numbers out there are not 988. That's above me, ma'am. I'm not
Right.
aware.
But the one on under your command or within your unit,
Yep.
your program.
So, yeah.
Do you know what kind of training, if any, they get to be answering these
So,
calls?
So it's my team. They're either licensed clinical social workers, licensed mental health care providers, nurse case managers that have case management training. So that's who's on my team, man. And
Okay.
yeah.
So if a call went into I'm going to call it your team's
Yes, ma'am.
helpline, is it appropriate for a helpline employee to tell family members that if they get mental health help for their soldier, that it could hurt their career?
As I mentioned, or no, that I wouldn't like to hear anyone, because that's going to restrict someone from seeking care. So So I don't think.
Okay. And just so I am clear on the record, if a soldier, a reserve soldier who's on active duty orders is ordered to undergo a command-directed mental health evaluation at a military hospital, that report, the results of that report would go up through the chain of command, as you said. Is that correct?
No, the medical record does not go to the chain of command. No. So it's that profile. A profile would have to be generated, and that's the communication. And so it's basic elements, if you will, but not the medical
Not the full
record.
medical record.
No, ma'am.
And is there a Army document number for that profile? So many Army documents have, AR and then something.
40-501 and 40-502.
40-501 and 40-502. Okay, thank you very much.
Yes, ma'am.
Colonel, I have just two follow-up questions.
Yes, sir.
One is if a service member was referred to a civilian outpatient program, not then the person and the people who did it didn't contact PHP. You have no way of knowing that unless someone, including the commander, tells you that so-and-so was referred to this program, correct?
You only know what you know. Yes,
Yeah,
sir.
okay. So, and then even if you do know, sorry, so like so-and-so was referred to Clinic A, and you didn't do that, would you still have the authority or ability to check in with them and say, hey, can you let me know if a service member doesn't follow up? Or is that pretty much, okay, there's nothing we do because they follow a civilian authority?
It's based on the acuity. If
Okay.
there's concerns, then they
Okay.
continue to reach out.
Okay. All right. And if any service member anywhere in the country get treated and someone in the treatment team had made a determination that the person is not able to, there's significant concern for firearms, does that get bumped up automatically to PHP, or would there be flag, or it raise a different level? I mean, if someone got treated and they're feeling better, okay, they sent home kind of thing. That I could see some of that. But if people are saying there is a concern about this person, future well-being, including safety and ability of firearms, would that trigger anything to involve PHP?
If so we document that on the profile.
Okay.
And that's how so if there's a behavioral health condition that's warranted, that we generate a profile, the Army writes that on their profile, sir.
And does that put a different level of oversight compared to someone who doesn't have that flag?
That's what one piece of the puzzle, sir.
Okay.
As you're aware, there's multiple different things that increases someone's risk factor for SI-HI.
Okay, but that certainly is one thing that would add to that concern list, correct?
Yes, sir.
Okay. And lastly, at the end of the day, even if even if a commander knows about PHP, it is up to them to decide if they want to utilize it, correct? If they feel that, oh, this is not a big deal, I don't need to involve PHP, or the fact that I think I can do this in-house and try to talk him out and do whatever I need to do, PHP would not even be aware of this situation. Where
it's not a requirement, but we are their resource. We are their asset. Yeah.
Yep. If they want to use you, but if they say we're going to do this, whatever, or not knowing about it, you would never know about that, correct?
We only know what we know, sir.
Okay. Thanks again. I appreciate your time. So.
Yes, sir. Thank you.
I didn't appreciate that there were multiple, what I'll call 1-800 numbers that were available to contact various Army resources. Can you tell us what all of those numbers are and which ones would contact a member of the public with your team?
They may not necessarily reach out to our team because those are national no, they're either, the 988 is a civilian 911, that they necessarily wouldn't reach out to our team. Military One Source is a military potential that people can reach out to, but I don't, they wouldn't necessarily reach out to our team. There's Vet for Warriors, but all these are national level numbers, ma'am, that are up and out of where we're at.
Well, of those multiple national level numbers, which ones would you expect to make a referral to PHP if somebody were seeking help for a reservist?
I'm not aware of any that would reach out to us, ma'am.
So the existence of PHP is not something that somebody answering one of these 1-800 help numbers would be familiar with and be able to refer a caller to?
Not necessarily, ma'am. No. I have not dug into like Military One Source. If we are I would hope we have a link out there. I know we do on our reserve website, but at the national level net numbers, I couldn't confirm or deny, ma'am.
So there isn't a 1-800 number specifically for reserve members?
Not that I'm aware of, ma'am.
Thank you.
And I just have one quick follow-up question, just to follow up on Dr. Ng's question. So let's say a commander does not reach out to PHP. They have a reservist, however, who's in a acute mental health crisis, and they do a command-directed behavioral health evaluation. They order that. There are circumstances, I believe you said, where the PHP would become aware of that. Not 100% of the time, but there are circumstances where even without that sort of reach out from the commander, that the PHP would be notified that this command directive occurred. Did I understand that correctly?
Can you ask that
Sorry.
one more time, ma'am?
Yeah, no worries. So let's say a commander does a command-directed
Yes, ma'am.
behavioral health evaluation, but doesn't kind of knows the resources, knows the layout, does not reach out for help from PHP to accomplish that. The reservist goes into, ultimately gets hospitalized via through a military facility first and then into a civilian facility. There are circumstances when the PHP would know about that, even if the commander had not reached out for assistance. Is that correct?
Ma'am, yeah, the medical records, that's part of the ARMIC piece as far as looking at that profiling piece. And so they document it in their system of record MedChart that PHP has access to. So that's how they cross-level, cross-communicate, ma'am.
Okay, thank you. I just wanted to make sure I was clear on that. Thank you.
Yeah, yes, ma'am.
I assume that there are no more questions from my colleagues or the staff.
Excuse me, Chairman, if I could just ask a follow-up question or two. I apologize. Colonel Ochoa.
Oh, Jeff, just a second. We need to do a interpreter switch.
Okay.
Sorry.
Colonel, I think earlier in your testimony, you referred to something called a CCIR, which I wrote down as critical command information report, something like that.
Yeah, yes, sir.
And would that be ordinarily generated if there's been a command directed evaluation which indicates the need for further treatment?
Yeah, yes, sir.
And would that-
It can be, yes.
It can be, but it's not automatically.
Well, I would have to, so on the CCIRs, there's different levels and different requirements as far as what gets reported and to what level it is. As far as battalion, brigade, division level CCIRs and what gets reported.
But if it's a higher level report, would that automatically go to your unit?
If it's a CCR that goes to 3-star, then I see it and my team sees it.
3 stars meaning lieutenant general?
Yes, sir.
Okay, thank you.
Yes, sir.
Thank you, Mr. Chairman.
Right. Colonel, you may be relieved to know that I don't have any questions for you. My colleagues have done a very good job of exploring this. I just want to follow up on some of Mr. Rushlow's questions by explaining that we understood in advance that you were not a fact witness, but you were rather a witness who was going to acquaint us and public with the rather complex machinery that is available for mental health services for reservists in the situation in which we confront. And I think that today, hopefully we've demonstrated to the public and to ourselves that this is a complicated, complex process. And we do have, I want to just point out that we do have records regarding the operation of the PHP and the interactions with the commander, company commander. And for those of you who are listening in, you may recall that Toby Dilworth conducted a fairly methodical and extensive examination of the company commander regarding those documents. And I also would point out that we have underway an effort to obtain a fact witness with regard to those. And we hopefully will be able to do that at a later point. But so that's to give context to this. But it was extremely helpful to me, and I'm sure to our colleagues and the public, to hear your explanation of what is a very large and comprehensive program for providing services to members of the reserve. So we thank you very much for your appearance today and for your cooperation in this, and we appreciate everything that you've done.
Yes, sir. Thank you.
Okay. And I would close out by once again thanking the interpreters, and I'll do it my only sign language, which is hopefully conveys the same impression. And I thank my colleagues for a well-conducted session. And I particularly want to point out that our communications director, Kevin Kelly, arranged this rather, at least to us, unique situation in which we could present not only the interpreters, the witness, and our own persons, but also allow public and media to participate in it and to follow. So we preserve the public hearing requirement that we hold ourselves to. So thank you all very much. And if there's nothing further, we will leave, as the expression goes. There's a motion to leave, and is there all in favor?
So moved.
And seconded, and all in favor, including the colonel. So thank you all very much.